loads from each of the presentations. I'm going to do that classic thing. Yes, we've been doing online presentations for a good 4 years now, but can you see my screen? Can I get a thumbs up, something in the chat just to reassure me that you can see what I'm sharing?
We can see everything, Ella. Yeah, the thumbs are up.
Brilliant.
We can see and hear you perfectly.
Excellent. So my plan for this session is to kind of wrap up everything we've done today. You've learned some interesting things. You've learned about different identities, different experiences. And like me, you're probably full of inspiration and ideas. And so my intention is to help you find a way of translating that into your practice. And hopefully in an hour's time, you will have something you can take away with you and deliver in class next week, new academic year, whenever fits with your schedule. So to introduce myself, I'm Ella. I'm a mental health nurse by background, and my clinical background is mostly in forensic mental health settings and acute mental health. And my academic interests all health inequalities, all LGBT health, and finding the best ways to teach student nurses in particular, but anyone about LGBT health. It's such an important topic and close to my heart. So I also have a personal connection to this field, as is so common, with people engaged in this topic as part of that community myself in relation to my gender and sexuality. So before we start, by the end of this session, you will have, believe it or not, designed and prepared a case study about an LGBTQ plus character. So feel free, if you've got a case study that you already use that you want to edit, update, work around, get that up, get that ready to work on, get that ready, or get note paper ready to take notes, or feel free to start from scratch. And I'm going to take you through step by step how to write a case study in an inclusive way so that you can apply that to, I mean, all sorts of sessions we use case studies in, like clinical skills, in EBL, or even in like a very didactic lecture style class, just to illustrate a point. So have a think about, if you've already got something and you're thinking, actually, this would be a great place to add an LGBT plus character or example, or feel free to start from scratch, whatever works for you. We will also be using the chat function quite a bit. So I've set up my screen so I can see that, but there will be bits of audience participation, getting ideas, sharing ideas as well as we go. Lovely. So the first thing I want you to have a think about is, if you're going to try and put an LGBT plus inclusive case study into a class and into areas of your teaching, why? What is your intention? What is your purpose? What do you want it to achieve? Is it simply that you just want more visibility? In which case, absolutely brilliant. Love that. Have a look at more visibility. Have a look at diversifying the profiles of your case study cohorts. Or is it actually, no, I want my students to know about this specific experience relating to this part of the LGBT plus community. I want to teach on this specific health need. So before we go any further, have a think about what you want a case study to achieve, and the one that you're going to be working on today, and pop 1 or 2 aims for yourself, either those that I've got on the screen, or you can write your own and share those in the chat with everyone else. And we'll have a look at what comes through. Now, while we're waiting for those to be typed up and sent through, the goal that I'm going to have is I want a specific health need to be taught. So we're going to build a case study together. And what I want to focus on is around mental health needs of trans men. So I've chosen that because that's sort of where my wheelhouse is. That's where a lot of my expertise is. So it's something I'm confident with. And so I'm going to focus on the self-harm risks associated with trans people particularly for trans men. So that's my goal, is not just to diversify, but also to target that specific health need. So let's see what you guys have come through with. Increase representation in delivery to impact marginalisation in practice. Amazing. Teach about the influence of marginalisation. Love it. Yes. And I want to use an LGBT scenario to teach about specific health needs, but also want to use case studies that happen to be LGBT, yes, to teach on other issues, and someone is coincidentally, and that is what we'll come on to just next, for normalising. Diagnostic overshadowing, that's come up earlier. Yes, Helen, absolutely. That's a really good point. Having people with learning disabilities reflected everywhere. And a real issue that's very common is that infantilization and desexualization of people with learning disabilities, regardless of age. So absolutely, Helen, finding ways to put LGBT examples into your learning disability work would be brilliant. Oh, nice point from Morag about using the minority stress model. Excellent. Look at this. To add to what we already do across the curriculum. Love it. Okay, so you guys have some really good goals. Fab. So what we're going to think about next, and it's come up a little bit in some of the comments people have made, is about representation. And there's kind of two forms of representation. I'm sure they have official names according to the literature, but I'm not sure what those are yet. So for me, I refer to it as passive and active representation. So passive representation is that coincidental thing. Your patient character has an identity characteristic, in this case an LGBTQ plus identity characteristic, but it's completely unrelated to their care needs. Whereas active representation is it's necessary for that character to have that identity characteristic because it influences their care needs. So some examples I've got of passive representation would be Emma attends the GP nurse's clinic for a blood test with her wife Sue. The fact that she's gone with her wife Sue and not her husband John makes absolutely no difference to the process of taking Emma's blood or to the process of the clinical intervention there. So that's passive. It's just, by the way, not everyone's heterosexual. And that's a really nice, easy way to do things. Equally, when we use patient volunteers, we've got a little bank of case studies that we use in a final year module where we have patient volunteers for exams and for practicing clinical history taking with. And so each of those are written as either different sets of names, different sets of pronouns. So we have Alice Alistair, and we have Dawn Dave, and we have a Jenny Johnny, so that regardless of which volunteer comes in that day, we can just tweak the case study names and pronouns so it fits whoever we're working with without it changing the clinical content at all, or at least not very much. So we have Alice Alistair, and they come into A&E with signs of mania, and that's the focus. That's what we want the students to be picking up on. And she has very limited insight into her health. So has actually been brought in by her husband, Lewis. And I remember the first time we ran this was a few years ago now. And one of our patient volunteers that came in to be an Alice Alistair was a man. And so he was going to be Alistair, and he said, would you mind if we changed it to be that I had a wife, I don't know, Louise? And we said, actually, no, it's quite helpful for it to stay as Lewis, and we'll see how the students respond to that. And the students were wonderfully accepting and didn't sort of bat much of an eyelid as well, which he remarked on afterwards. And it's just a really nice, subtle way of, if you've got characters who have relationships, you can gender swap the main character, and then that may, depending on who is there, create either a heterosexual or a LGB relationship. So the name and pronouns change regardless, depending on who is there. So passive is all about that coincidental representation. So-and-so just happens to have this identity characteristic, whether that is an LGBT identity or any other identity characteristic. This doesn't just apply to LGBT representation, but it's purely coincidental and it doesn't really impact on their health needs. Whereas if we look at active representation, we're going to go back to Emma. While she was in that blood test appointment, the practice nurse recognised, oh, she missed her last cervical screening, and invites her to arrange a new one. But Emma says, well, no, I don't need a smear test because lesbians can't get HPV, and so there's no point checking for something that I don't have. Now, this is a really key issue when it comes to cervical cancer screening, but also in general, a real health disparity. So women who have sex with women often are under the common misconception, as are healthcare professionals delivering these services, that it's less necessary. And so of people over 25 who need cervical smearing, 15% of women who have sex with women have never had a smear, compared to 7% of heterosexual women who are eligible have never had a smear. So more than double. And so that's where you've got active representation, because actually her sexuality, the fact that she's there with her wife, is relevant to her clinical needs. So you can start sort of drip feeding that representation. So thinking about the case study you want to use and how that relates with the goal that you've set, have a think, do you want to use passive representation? Is that enough? Is that going to give you what you want? Or do you need to think more about active representation, where the identity is meeting that person's health needs and there's an interaction there? And I can think of loads of different examples of sort of passive and active representation. So again, yeah, pop in the chat just the words passive or active or both, which one you're thinking might fit best with what you've got planned. Grace is going with an active approach. Az was going for a bit of both. Lovely, some active with Marissa. Active with Helen. Active with Gail. Yeah, lots of active. And it's a really nice approach to use to get specific health needs onto the curriculum and address things directly. So the next stage is to build the case study from a clinical perspective. This is always the priority. You always need a case study, regardless of what you're doing with it, to be clinically relevant, to be clinically effective, to be clinically sound. So now you've got an idea of your goals and intentions for where you want that representation to go, what you wanted to achieve. Actually, we'll pop that to the side a moment. Build your case study from a clinical perspective. So using these questions, using any other questions that you typically use to guide yourself through building and writing a case study or a character. Have a start thinking about, okay, what do we want their primary diagnosis to be? How acute do we want this to be? How long has this been going on? Have they got any key comorbidities? And have a think about, if you're using active representation, which diagnosis or comorbidity is clinically relevant. And if you're using passive, you're all good. Just write it as always. And then when we come on to more of the sort of social identity factors, that's where you'll come through. The other thing to think about when writing from a clinical perspective is, of course, what are we doing with it? Which type of class am I bringing this into, and what do I want my students to do? And that will often have a tweak on as well when I'm thinking about designing a character, how I'll use this. And so often, I think many of you will have experience of this as well, the best case studies are the ones that take elements from real people and are based on people we've worked with in clinical environments and have got to know as whole people, rather than trying to pull up an idea out of nowhere. So I love bringing in like a touch of different people I've met into different case studies. So have a think about what's going on for your patient. And the last question on that slide is, are there any complexities with meeting that person's health needs? And I've used the word complexity in the broadest sense, possible. So this could be around disability, so physical disability and the physical accessibility of your service that you've chosen to locate this scenario in, of the building perhaps, or it could be about the language that you use. So if somebody is deaf, or if they are blind, are you communicating in an accessible way? But also about learning disability, again, heavy on, are you communicating appropriately with that person, for that person? You might also be thinking about other aspects around disability, but also complexities for mental health, of course, can be about social factors. So financial, home environment, health literacy, language, general literacy, whatever. And what's really interesting is when you look into the impacts of marginalisation on anyone, but also particularly on LGBT plus people, you see much higher rates of these social restrictions and social impacts that can influence not just how someone lives their life, but how they interact with healthcare. So we see reduced rates of completing education to the standard level, often because people have been pushed out through issues of bullying. We see reduced rates of higher education among the LGBT population. We see increased unemployment amongst young homeless people. I believe the statistic is it's about half of young under 25 homeless people are LGBT plus, and often that is associated with issues of estrangement. But also we have issues around increased drug use and drug dependency within this population. So thinking about how might those other marginalisation impacts in other areas of someone's life that LGBT people in each identity characteristic within that broad acronym is more likely to experience. Not guaranteed, but more likely to experience. How might that interact with other aspects of health-seeking behaviours, for example? So it can bring up other factors of marginalisation and deprivation elsewhere as well. Brilliant. So have a think about what primary diagnosis you'll go for. And I think because we've got such a broad range of clinical and academic backgrounds, loads of people are going to go for different things. So that's brilliant. So you'll have an idea what you want to do clinically and how you want that to look. You've got an idea of comorbidities they have, how long things have been going on for, and also what complexities you've got going on for adaptation. And the complexity that I love going back to all the time, because it's such a good example for problem solving, is around literacy. And although not necessarily a high risk for this population, it's one that I just generally find really encourages students to think, oh, actually, yeah, how would I do appointment reminders if my patient can't read, or if my patient struggles to read complex language? A letter detailing their care plan isn't going to be really effective. What can we do instead? And so that's just a nice one that I tend to use to add to that complexities list. So moving on to the next stage is stage 3. And we're now going to think about, particularly for those of you using active, which from the chat is most of you, is thinking about, okay, now we've got the basis of the clinical setting, the clinical scenario, what's going on for my patient. We also need to think about specific health needs of our patient's population. So to work that out, I mean, we need to work out which LGBT identity or identities your character has. So whether that is chosen because of familiarity, you already have a good established knowledge about an identity, or whether you're thinking, actually, we don't have much about this identity or experience in our curriculum. Whatever is going on for you there, have a think which identity or identities do you want for your character have. And when it comes to clinical relevance, particularly if you've chosen multiple LGBT identities, so something relating to sexuality, something about gender identity, are they all going to be clinically relevant, or are you going to have one clinically relevant and one just as a passive representation? So have a think about how you want that identity, or those identities plural, to interact with your patient's care needs and their health as well. So have a pop in the chat which identities you're thinking about using, thinking about reflecting through your case study, and we'll see what's coming through from lots of different people. And there will be all sorts of reasons you've gone for different choices as well, which I always find interesting. But yeah, let me know which identities you're leaning towards using and giving to your character. And then once you've chosen that, you can then start going down the path of, okay, actually, what are some of the specific health needs of people with that identity? And so you may have established knowledge, you may be really confident of, actually, I know really quite a good amount about the specific health needs of gay men. Brilliant, off you go. I have a really good understanding about the health needs of transgender people. Brilliant, off you go. But actually, it's completely fine and completely normal to think, I'm not too sure about this. I would love to have some representation of asexual people in my curriculum, for example. And Katrina's inspired you. She's made you think, actually, yeah, we do need more asexual representation. Don't know where to start. Have a look at some of the resources that have been shared out today. There's been loads of great stuff in the chat, loads of ideas from different presenters. And I'm going to give you a few more in that box at the bottom of the page. These are some of my favorites. I think the book by Dr. Ben Vincent, Transgender Health Practitioner's Guide, it is absolutely brilliant. It does read a bit more like it's been written for a medical perspective, and that is Ben Vincent's background as a physician, but it absolutely is applicable to nursing and midwifery practice. It's very accessibly written and really does cover so much of trans and non-binary healthcare, which is absolutely brilliant. But there's also some resources in there that are more population specific or more health need specific, so mental health and conception related focuses. And often when we're thinking about, well, how do we get something authentic and meaningful that represents this population well, I would really strongly recommend having a look at Stonewall's 2018 LGBT in Britain reports, if you haven't already seen them. There is one focused on health that I think is brilliant. There's some focusing on education, on the workplace, on trans people's experiences specifically, but the health report is a nice place to start. And what's really good about that is, as well as the quantitative data that shows you some of the issues around healthcare needs and healthcare experiences in particular, which I think for me have been what's been most impactful, is that healthcare experience data. There's also some really good information in there with quotes directly from people about their experiences and their healthcare needs that are very thought-provoking, but also can help you bring that real personalized aspect to a character and some more authenticity as well. And you could take those quotes, for example, and sort of introduce them as something your patient character has said to you as the clinician, to inspire some conversation about, oh, well, what's actually going on for this person and where has this come from? Oh, and we've had another good suggestion as well. Brilliant. Mukherjee et al.'s Clinician's Guide. Brilliant. Thank you very much, Marissa, for sharing that. That's not one I've heard of, so I'm going to have a look for that myself as well. Brilliant. So have a think. If you are aware of the specific health needs of your chosen population, brilliant. Get those down. If you're not, no worries. Just make a note and spend some time having a look. And Jess made a really good point this morning about looking for reliable resources. So always using the critical thinking skills that we teach our students when accessing data on LGBT plus healthcare, because unfortunately there are some very dubious sources that get published and get into the public domain a bit more readily than some of the really genuine and effective research that goes on. Awesome. Can we check, how are we feeling about our case study so far? Are we feeling like it's starting to take a bit of shape? Are we stuck on any bits so far? How are we getting on? Oh, Morag shared a health needs assessment that's been great for public health. Brilliant. Thank you, Morag. And absolutely, any resources you've had that have been particularly helpful for things that you've worked on before, please do share them out. That's the whole point of the network, really, isn't it? It's that sharing best practice and sharing from our experiences. Brilliant. How are we? Oh, look at this. I was going to say, how are we getting on with putting our case studies together? Are we feeling good? We're feeling up to it. the next stage is going to be putting together an example together, kind of co-writing an example. So we've got Trans Reproductive and Sexual Health Justice Embodiment Agency. So that's another book that's been suggested as well. So thank you, Asma, for suggesting that one. That's brilliant. And loads of these are really new as well, really up to date, which is so helpful and so important. Awesome. Yes, having a look at easy to read. There's some really good easy read guides and booklets and resources online that have information about LGBT health in easy read formats. There's some really good ones out there. I can't remember off the top of my head who has shared them, but they are out there, I'm sure. Brilliant. So what we're going to do is I'm going to sort of, here's one I made earlier. I got halfway to building a character that I'm going to use and build out more fully. But also, if you've got partway through this and you're thinking, I'm a bit stuck here, it's all good. You can join me in writing this case study, and I've given you half of the answers already. So using what we've done in steps 1 to 3 so far, we've got our goal. My goal that I chose was teaching students about self-harm risk specific to transgender people. And this is directed largely at nursing with a mental health focus, but would apply to any field of practice. It's clinically relevant to all fields of practice and all areas. Absolutely, Helen, that's coming next. You're predicting the future. And so what I want you to do is sort of fill in the gaps for your character of each of these points. So we've got the goal. You might have the class topic or the clinical skills focus. So sort of the task, the learning objectives that you've got going on. Primary symptoms, we've got that. Yes, Diane, absolutely. I'll come to that in a mo. Have a think about what's going on for your patient, and what I'm going to invite you to do so that we have a character for all of us to take home at the end, as well as any that you're going through by yourself, that you're writing by yourself. If we can get some examples of, if you can give my character some acuity and duration of their restrictive eating and their distress at their body image, if you can help me identify how successful is their care plan going? Is it going really well? Everything's smooth sailing? Or is there something going a bit awry? Or are we really struggling with making this care plan work? There's something going wrong. And absolutely we can do that. And thinking about complexities. So if you can put suggestions in the chat for a sexuality for my patient as well, what's going on for this character? Possibly Diane, yes. So yeah, Diane has asked in the chat, is this dysmorphia? So I've given my character, who is a transgender man, symptoms of restrictive eating and distress at their body image. Now, this could well be a sort of pure and simple restrictive eating disorder risk case, but there could be something else going on that is population specific. So one risk factor that we see, particularly amongst trans men and transmasculine people, is restrictive eating. Unfortunately, that is in part to manage gender dysphoria. Absolutely, Jess. Because if we think about what it achieves, so a trans man is someone who is assigned female at birth but is a man, or if they're younger, are a boy, and so therefore they might have breast tissue that is unwanted. They might have more fat distribution towards their hips that's undesirable for them, and they may have they may menstruate. And again, as a trans man, those can be 3 very dysphoria inducing experiences or traits for somebody to have, and so one way that eliminates those is a very, very low body fat, and so it's a key risk for trans men and transmasculine people who are assigned female at birth to restrict their dietary intake, seeking to lose significant weight to reduce those dysphoria-inducing characteristics. And so it's a really key risk to be aware of in this population, and something that for this case study, I want people to be thinking of and taking into consideration. So absolutely, there could be elements of body dysmorphia. It's definitely elements of gender dysphoria going on. And we've got a suggestion from Diane for acuity and duration, low level, but over a long time and longer to notice by others. Lovely. So I've got a little grid. I'm going to make notes here. Duration. Lovely. So long term and a slow build, slow escalation. Could there be an element of restricted mobility and trying to manage weight gain associated with that? Absolutely. So as like one of the complexities of healthcare, we can bring in a mobility restriction, and therefore sort of balancing the restrictive eating with how mobility and movement is impacted there. Absolutely. Great idea, Morag. So where is that? That is in my, what are they called? Complexities. So I'm going to take notes, and then when we get to the end, we'll put it all together, and there's kind of an ad-libs template that I've prepared. So depending on what comes through, we've got ideas. So complexities, possibly different representations in different social groups. Diane, can you tell us a little bit more about what you're describing there? Lovely. And if someone can pop into the chat what sexuality we're going to give to this character as well, and how successful our care plan is going. Got you. Lovely. So they're going to be asexual. Thank you, Asma, for that one. Where are we? Here we go. Pansexual from Marissa's case study. Excellent. Lots of diversity here. Oh, Marissa's given us loads of details. Brilliant. Okay. Fab. Could have Prader-Willi syndrome and have been behaviourally managed to the nth degree. Absolutely. And that would be a real complexity of managing that person's care, wouldn't it? So there's loads of different directions you can take your own pieces in. And this is what I absolutely love about designing case studies, is they start to come real and start to build out a full person. So for our character, we've kind of got a good understanding of what's going on for them from like a health needs perspective, but we haven't yet considered anything really about who they are as a person, rather than just who's next on the waiting list, or who's in bed 8, for example. We've got their clinical handover, but actually, who is this? Who is this person? And so that's the next stage, is rounding out your character. So yes, we know what's on their handover. We know what's clinically relevant, but actually what else is going on for this person? And one way that I think is a really nice way of thinking about this is, I have a colleague over in our School of Medicine who teaches on the graduate entry medicine program, and over their program, for one of the years, they have 40 characters that they study in a PBL format. So every week there is a new case study character and a new scenario for PBL, EBL work. And so in reviewing the characters, not only did she notice that very, very often the medic clinician in those scenarios was a man, and so she's edited it so there's either gender ambiguity, we don't know what gender this clinician is, or there's as well some alternation, some diversity there in gender identity, so that we're not just getting he is the doctor, we'll also get some she is the doctor, because that represents our student and graduate population. And so as well as looking at the clinician's identity and who they are and their clinical background. As well as that, she's looking at so many components of social identity to ensure that that reflects accurately our population of patients. And so looking at each of these factors that you can see on the screen here, so thinking about a variation of age, variation of ethnicity, education, and health literacy in particular, so that we can practice with students adapting our ideas, our problem solving, our interventions to make sure that they fit this person specifically, but also so that we get no nasty surprises when we go out into clinical practice and think, oh, I've never met somebody like you. And the beautiful thing about case studies, as you will all know really well, is that thing of, I've met someone with some of the same characteristics as you in this case study. Let's go back. This isn't totally new. And I got a bit of confidence here with what to do. So have a think for your characters about each of these points. And some of you might be thinking, but Ella, this is so much. There is so much here, and not all of this is necessary. And that is completely fine. Not all of it has to be necessary. You might be doing a scenario where actually the clinical focus and some of these social focuses will be relevant and will be necessary, but not all of it will be, and that's completely fine. You might be doing something a bit more in depth, or where the social background is really clinically relevant. And for me as a mental health nurse, that's a very, very common experience, is looking at what's that person's social history to answer, well, how did we get here? How did we get to this point of mental illness or deterioration of mental health? So start rounding out your characters, whether that is the ones that you've already got and you're tweaking to give them an LGBTQ plus identity, or whether this is starting from scratch. Have a little think. And what I'm going to ask you to do is, for our character who we met on the previous page, so our trans man with restrictive eating, if we can get a suggestion for his name, if we can get a suggestion for how old they're going to be, and for each of these characteristics on this list, that would be excellent. I will fill in the gaps if there's any gaps, but if we can get some ideas in the chat. I'm always terrible at thinking up names. Brilliant. We've got Sam. He's going to be 25. Got Peter and Alex. Oh, he could be as young as 15. Absolutely. Brilliant. What ethnicity is British Pakistani? Excellent. Fab. So what we're thinking for, we could be Afro-Caribbean. Absolutely. Thinking about, what job does he do? Is he unemployed? Are there restrictions to him working? We've had this point about mobility restrictions. How does that interact with his job? He's a medical student. Lovely. And what's his housing situation like? What kind of home does he live in? How stable is that? Who else lives there? What's going on for his housing? He's in student halls. That makes sense. And he's 25. He's a mature student. Lives with mum, who's a feeder, which Helen ties in for your Prader-Willi syndrome example. Brilliant. And we're going to assume that the other occupants in his housing are other students, other postgraduate students. Or he's in a one-bedroom flat with a poor standard. Absolutely. Insecure tenure. And then from that example, Marissa, you've got loads of places you can take that in relation to the health impacts of a poor housing, so particularly issues around mold and respiratory health care, for example, and that is a classic issue. That's an increasing issue. Issues around keeping the house warm, bringing up cost of living crisis impacts on people, whether that is financial impacts or health impacts. You can go all sorts of different places. And yeah, insecure tenure and managing private and social rented accommodation where there's insecure tenure. Brilliant ideas. Asma's suggested that he is Muslim, so I add that to his religion. Lovely. And then when we're thinking about religion, all sorts of religions as well, is thinking about how his LGBT identity will be considered or received by his religious community. And exactly that point, as was put there, about struggling with religion, whether that is his relationship to religion or his community's response to his gender identity. And there's a researcher at, I want to say she's at York University, Sue Westwood. This is her whole thing, is looking at the interplay between religion and health and social care. So there's some really interesting articles and work coming through from Sue Westwood about how those two concepts interact for lots of different religions as well, lots of different major religions. Parents want him to care for them, especially when he's a qualified doctor, and they're very proud of his status. Brilliant. So that's thinking about what's his relationships like with family. Although he doesn't live with family, we don't know if they live locally or far away, but they want him to care for them. You're a doctor, you've got the clinical skills to do this. You can look after us as we get older. It's probably something many of us have heard at some point. It's that thing of, well, you're perfectly suited, this is your profession. But also that really positive aspect of them being very proud of his relationship with his skill set, and social cultural values, absolutely. So we can add that into our key relationships point, but also in relation to the quality of those relationships, and potentially caring responsibility. If he's already looking after and expected to be looking after his family. So let's get that written down. Parents want him to take care. Yes, absolutely. Potential pressure to make a good arranged marriage, looking at marriage, romantic relationships. How does he feel about that? How will that work for him as a transgender man? What is his sexuality? Particularly as he's asexual. Yes, Tina, absolutely. So I'll pop it up. It's on the last slide, but absolutely I can share that as a blank text in the chat. Yes, so this point came up earlier in Beth's talk about culture and expectations in lots of families about expecting a normal child and what their expectations are about imagined futures. And this is a big point that comes up around families and parents for lots of different circumstances, but again and again and again for LGBT people, is there's an issue of family members, particularly parents, thinking, having an experience of grief over a perceived and imagined future for their young person or even adult child. And I find it quite difficult to understand, because I'm thinking, well, actually this person is more themselves and often will be feeling more confident, more comfortable in themselves, and therefore, if anything, you've got a gain of someone who is feeling more confident, feeling more comfortable, more authentic, rather than a loss to grief. But I can appreciate that for many people it can feel like a loss of an imagined future and an expected future. So as a trans man, he would be raised in the sort of social role as a girl, and therefore may not fit that imagined future that his family have had for him. So absolutely, what is normal? But there will always be prescribed expectations, and different people will have different normals. And my favorite example for what's normal is asking a group of students, what do you all do for your birthday? And sort of thinking about what are your traditions for growing up around your birthday. Some people would have done presents before school, some have done presents after school. We'd have had all the aunts and uncles and grandparents over for dinner. We would have gone out for dinner with just my parents. Everyone will have something really, really different. And it's such a universal experience of what do you do for your birthday? And I could ask all of us here, even as adults, established adults, each of us will do very different things for our birthdays. And so what is normal, even on something completely irrelevant to our health and social needs, is a really nice way of introducing that. And absolutely, Janet has made a good point about for Jehovah's Witnesses, they don't celebrate birthdays. So that's another point a student could come in and say, Or actually, we didn't do birthdays and we didn't do birthday cards because that doesn't align with my religion and my culture. So lots of different things going on for these characters, and we can put that together and represent loads of different identities and lives and experiences through a diverse suite of case studies. So let's have a think about how, oh yeah, one point that we haven't got on here yet, and to be fair, I didn't really list it, is what does he do, how does he spend his time? So we're going to assume he's a medical student, so he's going to be pretty busy with studying, but can we get a suggestion of a hobby for our Sam, being mindful of mobility restrictions? Let's have a look. Video gaming. Lovely, thank you, Grace. Yeah, gaming's a great go-to. Loads of really interesting points around community with gaming. And I'm also just coincidentally in the process of doing a study on identity development through role-play gaming. And while that's more focused on tabletop rather than video gaming, there's a huge correlation and crossover between LGBT people and using games to explore identity, and whether that's sexual identity, gender identity, it's like colloquially recognized as a big thing. So we're trying to work out what's going on for that. Helen's also suggested swimming. Absolutely, we can add that. He goes swimming in his spare time. Lovely. Brilliant. So he's got his classmates as key people in his life. Let's check. We haven't yet had a comorbidity. Would we like to give our character a comorbidity, or are we going to stick with simply the food restriction? Oh, what's this? I know we take that as mobility. Yes, Valeria, that's a really good point about what's his motivation around swimming. Is it a fun, casual swim, or is it a very sort of key focus on cardio for calorie burning? T2, type 2 diabetes mellitus. Yeah, we'll go with that for comorbidity. Type 2 diabetes mellitus. Brilliant. Yeah. Something common, something they should have familiar with, but also if they don't, it's a really good point to bring it in, and thinking about how that will interplay with food restriction as well. Yeah, absolutely. Even walking a lot. Brilliant. These are great. So, oh, we'll go for type 1. We can absolutely, and then we can bring in considerations there around diabulimia. So if you're not familiar, because it's not in the DSM or ICD yet, but some, fortunately for a number of people, will manipulate their insulin intake if they have type 1 diabetes as a form of restriction, with similar diagnostic profile to anorexia and bulimia. So we could absolutely bring that in as a consideration. How is this presentation all fitting together? And as you can see, for this example that we've got going on together, there's so much happening, and he's really starting to round out as a real person. But also for your own ones, as you start going through all those characteristics, thinking about, well, who is my person right in front of me? And there might be characteristics that I've not thought about that are more likely specific to your field of practice. So I know I'm not very familiar with children's nursing. I know I'm not very familiar with midwifery. So there might be points that are coming up for you guys who are in fields that I'm not as familiar with, that I haven't even thought about. So absolutely brilliant. So we've rounded out our character. We've got a really good idea of who they are, what our students are going to do with them. So for this character, I want my students to practice taking a mental state exam and to be able to identify the 5 Ps for this person, thinking about what are the precipitating, perpetuating, protective, and so on factors for our character's mental health. So I can give them all this information and they can go, okay, here are the 5 Ps and this is what that's going to look like for our intervention. Excellent. I love that for you, Janet. It's tapping into your inner philosophical mental health nurse. That's what I love to hear. That is exactly what I love to hear. Brilliant. Now, we've talked earlier, I say we, not me, but we've listened earlier to thinking about red herrings and diagnostic overshadowing. That was a word that came up a fair bit this morning, and it's a really, really big topic in literature on LGBT people's experiences of healthcare, and one of the barriers to good healthcare experiences, but also that can make people from lots of different LGBT identity groups resistant and hesitant to access healthcare services, which of course delays intervention and can reduce quality of outcomes as well as a result of restricting early intervention. So it's a big factor to think about. And so an optional aspect to your character could be a red herring. I'm all about it when it is used with experienced students. So if this is their first time doing working with a character who has an LGBT identity, probably not the time to do a red herring. But if you've got an experienced student group, go for it. So I do a lot of work with third year students on third year modules. So for me, all the time, I can get it in, and we can do that thing on, well, actually, that's just coincidental. And it's a really nice way of bringing it in for if you've got any postgraduate students as well, any advanced students, getting them to think about diagnostic overshadowing. So I'm going to use depression as an example, and I'm also going to bring myself into this example of where we have issues around diagnostic overshadowing for LGBT plus people. So regardless of which part of the LGBTQ plus community somebody is from, whether that is about being part of a sexual minority, a gender minority, being intersex, or fitting into that community in any way, everybody within that population has an increased risk of developing depression, and in many cases increases risk of self-harm and suicidality. Poor mental health is a really, really huge risk factor for LGBT plus people. And so in my own experience, I have depression. I've had depression for many years, and I've worked around that and worked with that. But actually why I have depression has nothing to do with the fact that I'm not heterosexual and that I'm not cisgender. So as much as being a non-binary person and being pansexual increases my risk of developing depression, actually for me, that's got nothing to do with it. It's completely irrelevant. I would still be having the same experiences of depression that I've had if I was cisgender and heterosexual. And so I could use myself as a red herring character of Ella's come into your clinic with experiences of depression. Here is on paper this information. You're like, oh, well, the LGBT, high chance of low mood, high chance of depression. Here are all these risk factors. And absolutely those are there because of stigma, marginalization, discrimination at individual and systemic levels. So that has exacerbated my risk. But actually, one thing that people find very frustrating, and it comes through in literature on healthcare experiences, more often around sort of psychotherapeutic approaches, but in other fields as well, is this thing of, that's not actually why I'm here. This would have happened regardless of my gender identity or sexuality. So if you've got a group that you think can manage that, absolutely, we can throw in a red herring. And yes, Janet, for our character Sam, actually this eating disorder could be entirely irrelevant. While trans men have a higher risk of developing an eating disorder as associated with managing gender dysphoria and sort of feminine appearing traits and physicality or feminine experiences such as menstruation, absolutely this could be a complete red herring and have nothing to do with his gender identity. And it could be related to other factors that are sort of more typically associated with restrictive eating. So yeah, really good example. We could absolutely do that. And this comes back to a point that Jess made earlier today about trans broken arm syndrome. So those of you who are here this morning will be familiar about this idea of often trans people will have experiences with healthcare professionals where whatever's going on with them will be put down to the fact that they are trans, and particularly if they're on hormone therapy. Well, You're struggling with this gastrointestinal issue because of your hormones. You're struggling with this respiratory issue. It's your hormones. You've got a broken arm. It's your hormones. And Jess gave a really good example of see also you could do with losing some weight. And I'm going to add to that, see also, oh, it's because you're pregnant. And so this thing of diagnostic overshadowing, trans broken arm syndrome, it's a huge issue, and it's a clinical risk as well. So you can bring up conversations about diagnostic overshadowing and the clinical risks around that. What is the problem of assuming that something goes down to trans broken arm syndrome or other experiences that might be coming through? Awesome. So have a think. Do you want to add a red herring to yours, or are you going to keep it straightforward, depending on which group you've got planned to work with? Awesome. So I can see we're close to time, which means we are perfectly on time to put it all together for our case study. So this text is on the screen. This is our ad lib, and I realize it's a lot to go through, so I will read it out, and I will gladly copy that in the chat before we finish today, so that you can make use of it and tweak it as you like. But anything in the brackets is based on the answers that you have fed to me and that I've been taking notes on as we've gone through. So Sam is a 25-year-old British Pakistani transgender man. He's been referred to the, we're going to go with the primary care mental health team due to concerns around restrictive eating and distress with his body image. This started around, it's long term. We're going to go with 2 years ago, with him seeking to lose weight to reduce the appearance of his hips and breasts. However, this restrictive behaviour escalated around 6 months ago, following some sort of stress factor. Now, we didn't identify what that stress factor was, but we could say increased workload associating with his studies. In the past 6 months, Sam has reported losing, and then here you would insert a weight for this case study proportionate to his size, the acuity, and how long things have been going on for. I don't do numbers around weight, so we're going to skip that point, but you get the idea. And he's described this weight loss as being beneficial as it's reduced some of his feelings of dysphoria. So he perceives this as a really positive outcome, but he does show some insight into the possible impact of this dramatic weight loss on his physical health. So he's got really good insight there. Brilliant. And how will that interact with how effective our care plan goes? He does not want to restore his weight, as he anticipates this will cause an increase in dysphoria, which significantly affects his mood, self-esteem, and ability to socialize confidently. So thinking about that phrase, when we're thinking about, well, what are we going to do? What are we going to do with our Sam? We've got to think, particularly when we're working with more advanced students, about how would we want to, as practitioners, working with an MDT, balance this point of weight restoration and management safely, and thinking about his physical health needs with the mental health risk that could place on his mood, on his self-esteem, and his social interaction and social isolation risk. So there's lots of things to go on, lots of complexity bringing in here. And depending on what primary diagnosis you've given your character, I'm sure you can pull some complexities and some little difficulties in there to add a little bit of spice to your character and a bit of spice to what interventions you might be considering. And increasing that critical thinking skills. Although this intervention might work for most people, will that work for our person? So as well as the presenting issue, Sam also has a diagnosis of type 1 or type 2 diabetes, which is, we're going to say it's well managed. We're going to say he's pretty good at managing it, but actually there is a risk around the restrictive eating that maybe it's not as well managed as it could be or as it's reported to be. So that's all the clinical stuff, and then thinking about the social parts. Sam studies as a medical student and lives in student housing with other postgraduate students. He has a very positive relationship with most of his housemates and a good relationship with his parents, but he struggles around their expectations to take care of him. to take care of them as he develops in age and in his medical career. He spends his time swimming and playing video games, and then we can elaborate on what that involves further as well. And we can talk about spirituality here. So he also spends time praying and at the mosque. So we've got loads of information in there, and what you can do is pick out bits and tweak them and swap them in when you're putting that text together. But what we've done there is very, very quickly written a case study that you can now build upon, tweak a little bit, work out how it's going to fit into your class, how it's going to fit into your teaching, so that whether that's something you discuss in module development meetings or in your own independent lesson planning, you can get it into action over this summer or be ready to go for the new academic year with a LGBTQ plus inclusive case study. And so I promise, as you've seen, it's not too intimidating, I hope. It's very, very doable. And what I will say as well is you can use that same formula, use this same process to develop case studies that are inclusive of other characteristics. So thinking about, well, why do we want this inclusion there? Thinking about passive and active representation. What are my learning objectives in relation to this identity? How is it clinically, how is this person's clinical needs? Are they interacting with their identity characteristic, or are we having passive representation? And then let's build up a whole person. And it really works well to, if you've got lots in one module, you can get a bit of variety going on there as well. I'm absolutely loving these comments coming through. I'm so glad for lots of you. That's been really helpful and really encouraging. And that's exactly what I wanted, is to sort of reduce that intimidation barrier of, oh, but I don't really know as much about LGBT health as I want to. It's okay. Go for passive representation and just have a little nod to, by the way, here is part of their identity that you've got going on. So your final step is to make it happen. Make it happen. I'm not going to call it homework. I feel like that's a bit, I don't know if patronizing is the right word, but absolutely your homework is to go and make it happen. I would love to hear what you get up to. I would love to hear about the characters you design, but also if you get stuck at a point and you're thinking, Ella, can I have some help here? Yeah, absolutely, no problem. I've got my email address on the website. I'll pop that in the chat with the template that I've put together as well. And I will very gladly talk about inclusive teaching design any day with any of you. So yeah, brilliant. Thank you so much. I'd love to hear. We've got fizzy brains and lots of exciting ideas. Awesome. Awesome. Thank you very much, everybody.
Ella, thank you. How clever are you?
I try.
Yeah, absolutely. Well done. That was really, really fascinating to listen to and watch. Do you know, I was writing notes to myself because I need to make some clever comments towards the end. And I really love that kind of peeling the onion kind of concept where you're just peeling it and adding in another layer, another
I love a drip
problem.
feed. I love a drip feed for case studies of, oh, and here's something else.
And what next? And what next? Keep it as simple or as complicated as whatever audience you've got, whatever level they're at, whatever stage they're at, and chuck a couple of bombs in, or a couple of moral issues or philosophical issues. It's really, really good.
Oh,
so
bring in the ethics.
So much.
It's a great time to bring in the ethics.
Absolutely. And I see from the comments, people love you. So you've hit a point there. So thank you so much. We're really, really grateful.
Welcome. You're so welcome.
Right, and thanks for supporting the network over the past year. You've been a regular supporter, which is always much appreciated. Now, there's the lovely Caroline. Now, Caroline, do you know what I'm going to do to you?